sitting, your left hand lower
अनम्यूट
most.
कर दिया सर.
हाँ ठीक है, ओके, आप बोलो क्या बताना चाहते हो.
I am presenting the incidence, risk factors, and clinical characteristics and outcome of pulmonary embolism in COVID-19 patients.
Okay, hold on. You are presenting pulmonary embolism. Okay, now Pankaj has joined. Pankaj, please unmute yourself. I am muting, and you take over. Your audio is, Dr. Pankaj's audio is still connecting. Unmute. Please unmute, Dr. Pankaj.
Yes. Yes.
Okay, I am muting myself. Now you and Pritesh.
Okay. Pritesh,
Sir,
continue.
good morning, sir.
Good morning. क्या हाल है? ठीक हो? How are you? ठीक. Please continue.
Sir, today I am presenting the incidence, risk factors, and clinical characteristics and outcome of pulmonary embolism in patients of COVID-19. This study was done in Spain in emergency department.
Okay.
The aim of our study is to investigate incidence, risk factors, and clinical characteristics and outcomes of pulmonary embolism in patients of COVID-19 attending emergency department before this hospitalization. We take the patient before hospitalization, just before hospitalization, because we want to exclude the factors which are related to pulmonary embolism due to hospitalization, like prolonged bedridden and multi-drug treatment. So we took the patient only just at arrival of the hospital to exclude the hospital related factors. Sir, infection of COVID-19 is characterized by fever and respiratory symptoms with dyspnea and lung infiltrates. In more severe cases, many patients also present a procoagulant state, which is biochemically detected by increased D-dimer levels and is related to complications and worse prognosis. This study was done in on COVID-19 patients on arrival in emergency department before patient hospitalization. The objective of study. Objective is to determine the relative frequency of pulmonary embolism in patients with COVID-19 coming to the emergency department and to estimate the standardized incidence in general population. Second is to uncover the risk factors
Dr.
associated
Kritish,
with them. Yes, sir.
Go to the next slide. Objectives of study, you are speaking from next slide.
Sir, next slide is different.
Okay. Fine. Carry on. Sorry.
Second is to uncover the risk factors associated with the development of pulmonary embolism in patients with COVID-19. Third is to describe whether there is any distinctive clinical characteristics in these patients in comparison with pulmonary embolism observed in non-COVID-19 patients, and to investigate outcome of COVID-19 patients presenting with pulmonary embolism. Methods. Study design and setting. It is a retrospective case control emergency department based study, multi-center study that reviewed the medical reports of COVID-19 patients who attends emergency departments and were diagnosed as having objective pulmonary embolism during emergency department. Assessment and management before hospitalization of cases. Sir, this is a study forms part of unusual manifestations of COVID-19 project in Spain. UMC, so in shortly, we will told this UMC 19S9 project. Sir, in this study, we took cases and controls. Sir, controls are divided in three parts: controls A1, controls A2, and controls A3. Now, sorry, controls B. In controls, in cases, we took all COVID-19 patients diagnosed with pulmonary embolism during emergency department stay. Diagnosis is made by CT pulmonary angiography ordered during emergency department. In control, we have three control groups. Control group A1. A1 are the COVID-19 patients without pulmonary embolism attending to emergency department in the same period. And for we case these patients on the basis of clinical evidence of no clinical evidence of pulmonary embolism. Only 11% of patients had a pulmonary CT to rule out pulmonary embolism. In control group 2, we took all COVID-19 patients in whom pulmonary embolism is excluded by CT pulmonary artery in all cases. In control group B, it is made up of non-COVID-19 patients with a diagnosis of pulmonary embolism attending the emergency department during same period, as well as cases and also 1 year before the COVID-19 pandemic. Outcome. So there are 3 different outcomes are defined. Number 1, the need of the patients to be admitted to an ICU. There is prolonged hospitalization and all cause in hospital mortality. Results. So first, frequency and standardized incidence of pulmonary embolism. The overall incidence of pulmonary embolism were 310 per 1 lakh COVID-19 individuals per year and 34.7 per 1 lakh non-COVID-19 patients individuals per year. It means there is frequency is more in COVID-19 than non-COVID-19 patients. Sir, risk factors for pulmonary embolism in these patients. Multiple risk factors in which only 2 are very much significant. Median age is 66 years and 58% of these patients are male. The most common comorbidities with the pulmonary embolism in COVID-19 patients are: number 1, hypertension associated 49%, dyslipidemia associated 36%, diabetes mellitus it is associated 18%. And most frequent symptoms in COVID-19 patients with pulmonary embolism are dyspnea is in 72%, cough is in 78%, fever is in 45%, chest pain in 30%, leg swelling and pain in 14%, syncope in 4%, and hemoptysis in 2%. Sir, most common lab findings on arrival in emergency. Sir, SpO2 in less than 95% in 46% of cases. Respiratory rate is more than 20 per minute. D-dimer is more than 1000 nanogram per ml in 83%. C-reactive protein is more than 5 milligram per deciliter, and lactate dehydrogenase is more than 300 microgram per liter in 53%. Sir, there is inverse association with pulmonary embolism in COVID-19 patients. First is cough, second fever, and chronic heart failure. Sir, in chronic heart failure, mostly patients are taking anticoagulant already, so they have beneficial effect due to this already taking anticoagulant in CHF. So less incidence of PE in already diagnosed CHF patients. Distinctive clinical characteristics of pulmonary embolism in COVID-19 patients. Sir, there is ground glass opacity and bilateral interstitial infiltration on chest X-ray, diarrhea, history of previous thromboembolic disease, history of chronic estrogen therapy, and in patients of pulmonary embolism, main pulmonary artery is more frequently involved in non-COVID-19 patients, while thrombi is more frequently restricted to segmental and subsegmental arteries. Means in thrombi in pulmonary embolism in COVID-19 is peripheral and in the peripheral arteries, and in non-COVID patients it is in main pulmonary artery, right or left or main pulmonary artery. Sir, outcome of the study. Sir, ICU admissions was significantly higher in cases with control group A1, 18% versus 66.5%, and is control group A2, there is 18% versus 11.4%. There is no significant difference in mortality in cases than in control group A1 and control group A2 patients, but the hospital mortality cases were higher than in control group B patients, which are pulmonary embolism in non-COVID patients. Sir, in conclusion, Pulmonary embolism in COVID-19 patients is unusual at emergency department presentation. The incidence of pulmonary embolism is 9-fold higher than expected in non-COVID populations, sir. The UMC 19S9 demonstrates that pulmonary embolism in COVID-19 patients is unusual, about 0.5% at emergency department presentation. But standardized incidence is about 9-fold higher than expected in general non-COVID-19 population. So pulmonary embolism is itself probably does not increase in hospital mortality of COVID-19 population presenting to emergency department, as risk factors and lag symptoms are less frequent, and there is increase in D-dimer is lower than in non-COVID-19 patients presenting to pulmonary embolism department. So it is important that we should not wait the elevation of D-dimer to start anticoagulant treatment. Then it is a red flag sign for treating physicians for assessing COVID-19 patients in order to detect pulmonary embolism in these patients. So we should promptly start specific anticoagulant management. Thanks, sir. Sir, I have completed this.
Kritesh,
Yes, sir.
what is the take-home message from this study?
Sir, take-home message is that we should not wait for D-dimer levels in these patients of COVID-19 patients to start anticoagulation therapy. And
Yes.
Pulmonary embolism does not cause mortality in COVID-19 patients which does not have a pulmonary embolism. It means PE with COVID-19 patients have same mortality rate in comparison to non-PE with COVID-19 patients.
Okay. You are right.
Statistically.
Yes. As soon as patient of COVID arrive in the hospital, or as soon as he or she has been diagnosed as COVID, one should start anticoagulant, antiplatelet, anticoagulant in the form of glomerular or oral anticoagulants. Can you name them?
Dabigatran.
How does it act?
Factor 10.
Factor 10. No. Dabigatran does not act on factor 10. It acts on antithrombin mechanism.
Antithrombin, yes, sir.
You know, there are three categories: glomerular or factor 10 inhibitors, 10 or 10A inhibitors, which are new one, rivaroxaban. You know, I'm pronouncing wrongly, but it is rivaroxaban.
Yes,
okay, this is factor 10, which is available freely now, and thrombin, dabigatran. One should start with this treatment, and these drugs should be continued for long. These should not be stopped at the time of discharge. These drugs should be given at least for 1 month. Even if D-dimer levels are normal.
Yes, sir.
You know, we have been treating COVID since last 9 months, and we have treated almost more than 2,000 patients. So we have started anticoagulants for more than a month after discharge. This is our basic protocol. ICMR also recommend almost the same thing. Okay.
Yes, sir.
Dr. Grover, any more questions and anything you want to ask, please? Hello. Hello.
My question to Dr. Kritesh will be,
yes, sir.
How will you monitor anticoagulation?
Sir, if we are giving LMWS, then we can monitor by APTT. Serial APTT, sir. APTT levels.
Can you say that again?
Sir, if we are giving LMWS, then we can monitor by serial APTT levels.
Dabigatran?
Sir, dabigatran, for there is no monitoring is required for with the dabigatran. Monitoring is not needed required, sir. Sorry, your voice is not coming.
Dr. Amitesh. Well,
Kritesh,
Yes,
what
sir.
I suggest is, why don't you prepare a small lecture on this mechanism of anticoagulant, how do we monitor them? Basically, for low molecular weight heparin, this is not the way to monitor. APTT is not the correct way to monitor. It is for the unfractionated heparin.
Yes, sir. For LMWS, no need of monitoring.
Yes, you have
Sorry,
you have to monitor according through APTT.
In
Seven-
heparin, plain heparin,
yes,
sir, unfractionated
plain,
heparin.
unfractionated.
Sir,
So,
only.
you write down the name of the drug, write down the mechanism of action, the side effect, and how do you monitor it. Make
Yes, sir.
3 columns. It will take 2 slides. Okay.
Yes, sir.
In next
Okay.
presentation, whatever it may be, start with these 2 slides. Okay.
Okay,
So
sir.
that everybody get a revision, and these things should be on the tip. It is of practical value in the life.
Yes, sir.
Please.
okay.
And Kritesh, you are using these drugs on regular basis. One point I want to make: these are not the drugs which are discussing theoretically. You are using in live patient daily, so you should know all these things. These are very simple things.
Yes, sir.
Even these are discussed on round as well, but you are still not able to answer. I don't know why.
I think we'll go by Dr. Pankaj's suggestion. Let him make a small presentation. How about this Friday?
Yes, sir.
Okay, same time this Friday, Dr. Pankaj. You present a case and
It's all
in
right.
the end show these slides on anticoagulation.
It is very important. These things should be on tip, you know.
Yes, sir.
Being a cardiologist, you will be asked invariably when to start anticoagulant, what to give, when to stop, when to increase the dose. You know, you should be well versed with these drugs. And Kritesh, one more question.
Yes,
Do you see any pulmonary embolism cases in clinical life yourself? Can you describe
No.
any of the cases? What is the typical presentation of pulmonary embolism?
Dyspnea, sir.
Because this is the, I tell you, this is the most common dyspnea, very, very rare. Okay. Whatever you read in the book is not found in the clinical practice. Pulmonary embolism is a case which is very commonly been referred to the cardiologist because these are the mystery cases. You know, mystery cases. You will be sometimes you will be called upon by the surgeon, general surgeon. Oh, doc, my patient is having transient hypertension, but now he's okay. What do you mean by transient hypertension? Pulmonary embolism. This patient has suddenly dropped, there's a sudden drop in the oxygen saturation. Now he's okay. Pulmonary embolism. Dyspnea, pulmonary embolism. You know, these are 2-3 unexplained hypotension, unexplained syncopal attack, unexplained dyspnea, unexplained this chest pain. Sometimes, or most of the times in general practice, during surgery or general surgery or urological surgery, it is because of the pulmonary embolism. Until unless it is been ruled out. Okay. In clinical practice, it is the most common case referred to the cardiologist apart from MI. Okay.
Yes, sir.
And we usually miss it. अरे कुछ नहीं हुआ ये तो it is nothing. डॉक्टर साहब कुछ भी नहीं है ये तो हो जाता है कई बार हो जाता है. But how does it happen? It happens because of the massive pulmonary embolism. It's suddenly been thrombolized by the body system, and patient get all right. You say, "अरे कुछ नहीं है, ऐसा कुछ नहीं है." Okay.
Yes, sir.
Any more question, Dr. Grover?
No. I think we will meet again on Friday, and he will present a case, short case,
Okay.
and along with that, he'll discuss anticoagulation.
Yes, that will be great. That will be great.
Thank you, Dr. Bora.
Yeah, thanks, Dr. Grover. Thanks, Ritesh.
Yes, sir.
And Dr. Amitesh and Dr. Vikas both are joining.
Thank you, sir.
Thank you.
Thank you.
We have recorded this.
Okay. Thank you, sir. Thank you. Okay. See you then.